Welcome, everyone. I think we're very fortunate tonight to have a great speaker, Marc, give us this talk. Welcome, Marc. Marc Carrier is the current Vice Chair of Research and a professor in the Department of Medicine. He's a senior scientist in clinical epidemiology program of the Ottawa Hospital Research Institute. He holds a Tier 2 research chair in venous thromboembolism and cancer from the University of Ottawa, and a new investigator award from the Heart and Stroke Foundation of Canada.
It's really a great pleasure to discuss cancer-associated thrombosis. There's the lung cancer-associated venous thromboembolism, so a lung cancer case coming from Peter Cavan from McGill University. So 56, oh no, sorry, Mary the Curlis from Ontario. So 56-year-old theater producer, divorced, 2 teenage children, active 50-year smoker, the occasional THC, it's now legal, so it's all good, no alcohol. Reports reduced exercise tolerance, lately limited by dyspnea, no previous medical history, no current medication, BMI is 26. He presents the emergency room with a PE, so right-sided pleuritic chest pain. He's not tachycardic, satting is 93%. He's breathing a little bit quickly. Blood pressure is 140/80. He has sinus rhythm with right ventricular strain. Chest X-ray showed hyperinflation, possible right upper lobe mass. CNI is positive. CTPA shows bilateral segmental embolism in the right middle lobe and left lower lobe. There's presence of right apical mass, possible mediastinal invasion, neutrophilia on CBC, renal and liver function are well, and well-established lung mass, follow-up outpatient program. The patient in the emergency feels a little bit better after anesthesia, has a big play tomorrow night, wants to go home, so what do you do? Should you admit this patient? Should you agree with him and he can go home to attend his activies, and maybe revising the PESI and the simplified PESI and see what the score that he would have and what would be his risk of adverse events early, but also at 30 days, and then making a decision it'd be easier to admit this patient for expediting the results, or if the patient, and for observation because of his underlying PE, or can he be safely discharged home. Obviously, when we look at his PESI score, he's class 4, so he has 11% 30-day mortality overall, if you put all the points together. So what do? Do you admit him? Do you discharge home on normothylate heparin, on vitamin K antagonist, or directional anticoagulant? So we have mild COPDs on the PSC. The PET scan confirms the finding. Thoracic MRI confirms that he has mediastinal contact, apical invasion, no bronchial plexus involvement. He has endobronchial ultrasound at his schedule. And then depending on what the audience picked, what would be your procedure anticoagulation recommendation? If he's on normothylate heparin, when would be your last dose? Does this patient need an IVC filter or not? If the patient is on the directional anticoagulant, there's high or low bleeding risk procedure, you need to stop for 3 or 5 half-lives beforehand. And is that too much, or can you tailor it accordingly? So again, just to discuss, then he needs to have a transthoracic needle biopsy, so a little bit more invasive procedure. Would that change your peri-procedural anticoagulation recommendation? Is this a point where you would need to hold it for longer, decide to put an IC filter depending on when this is done in regards to the index diagnosis? Does it matter if he has DVTs or not? And what approach would you do, since you can confirm the squamous cell carcinoma is ready to be discharged home, he's now stable? What type of anticoagulants would you use? Because he doesn't have a high bleeding risk type of tumor. Would you look at additional risk factors or not, or would you prefer to use a parenteral or oral anticoagulation? Well, obviously drug-to-drug interactions will be important, and that's why we put the preoperative, so the neoadjuvant type of chemotherapy with cisplatin and etoposide. He has chest radiation as well, and he's planned for surgery in 10 to 12 weeks. So after 3 months, he has seizures. His CT head shows necrotic left frontal parietal brain metastases. He has no signs of recurrence on thorax and abdomen. Would you change the type of anticoagulants? You know there's some anti-seizure medication that may interact with the directal anticoagulants. Would that affect what type of anti-seizure medication you would use or not? Would you, for example, more likely to use Keppra instead of phenytoin, for example, or would you use an alternative form of anti-seizure medication? Would you avoid DOACs and prefer to use a parenteral low-microwave heparin? Is the fact that he has a single brain metastatic disease making a big difference? Do you feel comfortable about full-dose anticoagulation with patients with brain mets? We've also had some information about primary metastatic brain tumors on anticoagulation, making sure that the audience is aware of the risk of having VTE complication, the fact that the American Society of Clinical Oncology would recommend to still use full-dose anticoagulation. Most of the data around this is not very good. Most of the data is looking at vitamin K antagonists or low-microwave heparin. Some of the data will stratify if it's primary tumor versus metastatic disease. But at the end of the day, for most primary brain lesion or primary tumor, the risk of spontaneous bleeding is acceptable unless there's additional bleeding complication. And this is a systematic review by Jeff Zwicker and colleagues from Boston, just showing that if it's intracranial metastatic disease, the risk of intracranial hemorrhage, if you're on oral anticoagulation or low-microwave heparin versus not, is very similar with an odds ratio of 1.07. Different cup of tea if they have glioma, because obviously they need surgeries and they're more likely to have bleeding complication. I think it's still probably, it's probably the benefit of anticoagulation probably outweighing the risk associated with it. And just again, some data to show you that in that particular context. We talked about metastatic disease. This is for gliomas. So I was mentioning for gliomas, different type of T, odds ratio of about 3. But when you keep a glioma patient on anticoagulation, I know on the phone call there's folks that looked at this in very much detail about the risk of recurrent VTE and management of VTE in glioma patients. I think the risk of bleeding is high, but it needs to be balanced with a risk of recurrent VTE that is also very high. So a case-by-case discussion is certainly desirable. So for Mr. JD, at the end of his 9 months after brain surgery, he has infield recurrence in the brain, has developed progressive left lower limb palsy, still an anticoagulation depending on what the group has decided, and he has further brain radiation. And at this time, his condition worsened and he goes to hospice. So when he goes to hospice, what do? Do you stop anticoagulation? Do you decrease it to prophylactic dose? Do you have a discussion with the patient? Is it time to decide to stop anticoagulation depending on patient's preference? Because going from acute care to hospice or palliative care is a transition, but for which patients have strong preferences. So in a case-by-case discussion is probably recommended in most cases. The slide deck is finishing with anticoagulation continuing beyond the initial 6 months. We talked about acute, long-term treatment, initial 3 to 6 months, but a lot of patients will have underlying cancer, ongoing treatment, will need to have anticoagulation at extended duration based on, a risk of recurrence that is very high. Beyond 6 months, the option is often low-microwave heparin because there's a little bit more data with it. There's the TCAT study, the DeltaCan study showing that the risk of bleeding and recurrence in the month 6 to 12 is similar to the month 1 to 6, as you know. But there's also no reason why a directal anticoagulant would behave differently. We'll have more data, I'm sure, from the leukocyte VTE cancer patients, but continuation of anticoagulation beyond 6 months is something that is important to consider, and having the same discussion that you have whenever you're reassessing your patients on a 3 to 6 month basis in the acute treatment period will be important. Now, of course, if they cancer-free, they no longer have additional risk factors, then anticoagulation can be discontinued after the 6 months of anticoagulation. There's more arsenal now in our toolbox for management of cancer-associated thrombosis. You know, one would have liked to say that's easy as we used to use parenteral for everybody. Now we can use oral for everybody, but unfortunately it's not that black and white. There's a lot of shades of gray, and there's a lot of considerations. It's important to look at tumor types, additional risk factors for bleeding, drug-to-drug interaction, and maybe having a discussion with your pharmacist when we're not aware, keeping patients' preference, insurance coverage, and the additional risk factors that need to be done on a case-by-case basis, like extreme of body weight, for example, or additional risk of recurrence because of non-thrombophilia or other things are important to keep in mind.